Okay, so how about problem?
I wish I could work miracles, but what I can do is offer you some good advice and some good guidance for you to ask your care providers about how to help you if you are having symptoms of either urinary or fecal incontinence. So that's what I'm going to address today, and it's a great pleasure to be back with this group. I had the pleasure of meeting several of you last year in Anaheim and being in Nashville, the home of the Grand Ole Opry, as the late, great cousin Minnie Pearl used to say. I'm just so proud to be here, and indeed I am. But as you know, with scleroderma, you have multiple symptoms that can present either together or independently. And for many of you, you had to go a long time before even being diagnosed. You may have had to go from one doctor to the other doctor, and then because there's no one thing that they can look at and say, aha, you have scleroderma. And the same thing can happen with incontinence, independent of scleroderma, as people will present with different symptoms and they'll go to various doctors, but they haven't quite figured out the underlying cause. And that's always so important. We can manage symptoms, but understanding those underlying causes is really critical to continence management. So first, let's start talking about how things should work. Now, all of you, or you either have scleroderma yourself or you're a caregiver, and I'm sure you run into a lot of healthcare providers who you think, gosh, they need to walk in my shoes for a day to really understand what I'm experiencing. And I think that empathy factor and that ability to listen and communicate with all of our patients is absolutely critical. I spent the bulk of my nursing career, 22 years, managing wound ostomy, continence nursing, and nursing education at the Cleveland Clinic. So we took care of a lot of people who had complex wounds, ostomy surgeries, fistulas, as well as continence issues. And just to share a little bit about myself, I was born with multiple birth defects, and my parents were told that I would be incontinent of urine and stool, that I would probably be deaf and mentally challenged, I would never walk, and maybe the best thing to do would be to take me home and not feed me. So fortunately, they didn't need a second opinion to decide that they wouldn't do that. And so I obviously did have a lot of problems and had to go through multiple surgeries and was incontinent for most of my childhood. And I had ostomy surgery at the age of 10. And the person that took care of me was the very first specialist in ostomy care, Norma Gill. So it just shows you how we're all interconnected. And then Norma was like a second mom to me. And when I grew up, I became a nurse and I took over, inherited her position at Cleveland Clinic. So it's kind of unusual to have a WOC nurse who also has an ostomy and has had that problem. But I will say to you, I think it brings something to nursing practice or to your physician practice when either you've experienced or have had a very close family member experience some significant life change, because you're not the scleroderma patient in room 3. You're Marcy, who has scleroderma in room 3, and you have all of these multiple challenges going on as you're trying to manage your symptoms. And the fact that you're out here shows that you're a fighter. That saying is God only gives us what can make us stronger, or challenges that don't kill us will only make us stronger. But there's days when you think, you know what, thanks, I'm strong enough already. I just, I'm good. I can last for a little while longer. Thank you very much. But when it comes to continence care and skin care, because there are so many big issues that you face with scleroderma, with esophageal problems, pulmonary problems, kidney problems, sometimes the largest organ of your body actually gets ignored a little bit, and that largest organ is your skin. I mean, you see skin manifestations all the time, but usually somewhere along the way, somebody's trying to treat you systemically. And in healthcare, we do tend to be reactive rather than proactive. And I've always been very, very much a preventive queen, if you will, because if we can help maintain that skin integrity to help you avoid breakdown in the first place, it's going to make it so much more comfortable and better for you, because you always are going to have healing challenges, not only because of the disease process itself, but sometimes because the medications that you're put on can further impede your ability to heal. So how can it lead to incontinence? Well, let's first talk about how things are supposed to work. And these pictures make it look so simple, and our bodies are so wonderfully intricately complex. But what you need are 2 well-functioning kidneys. They are the world's best filtering system. You know, what we put in our bodies gets filtered through our kidneys, and it is just amazing how well they work and how they function. Their job is to transport the urine that is produced in the kidneys to the bladder. And the little tubes that go from the kidney down to the bladder are called ureters. And guess what those ureters are made up of? Smooth muscle. What does scleroderma like? Smooth muscle. You know, every part of our body that's both inside and then supported from outside is influenced by smooth muscle. So you can have thickening and sclerosing of your ureters that can actually cause problems of transport of urine down into your bladder. Your bladder is actually a muscle, a detrusor muscle, and the muscle that contracts to help empty your bladder is, guess what? Smooth muscle. So sometimes you'll have these symptoms, and your physician or nurse practitioner or physician's assistant, they're so focused on the other areas that they're used to thinking about, that you have issues with scleroderma. Sometimes it's easy for them to forget that our whole pelvic floor, our ability to empty our bladders, our ability to have intestinal motility and empty our rectums, that's all due to smooth action muscle and peristaltic activity that helps transport things along and then ultimately allows, say, the bladder or the rectum to fill and distend, and then to empty. So those are all critical components of how we would normally function. And of course, whether you have scleroderma or not, as we age, most people have some bladder problems or rectal problems. Women especially, if you've had babies, your kids cannot do enough for you on Mother's Day for what they do to your pelvic floor while you're carrying them. Because even when you're young, you have some muscles and hormonal changes that kind of help you keep things up in there and help keep things tight. But I bet you have either experienced or have friends who say, don't tell me a joke until I can cross my legs, and because I'll pee if I laugh too hard, or if you sneeze, or if you lift something. Those problems are only going to be compounded more with scleroderma if it affects that smooth muscle in your pelvic floor. And so when you look at the accessory organs that are really important to help maintain the location of the bladder, the ureter, and how things should empty, that is really important in everybody, but is especially significant in when you have scleroderma. And for that side with women and the problems later with after effects of childbearing, and then with men as you age, it's very normal for your prostate to enlarge. So you combine an enlarged prostate that can get pretty big, and the prostate then puts pressure on the backside of your urethra, which can make it very, very difficult for you to empty. Your whole urethral lining, all of that is lined with epithelial cells, and the ability to contract and relax sphincters. You have internal sphincters that are involuntary, and those are under smooth muscle control. And certainly sometimes biofeedback and biostimulation can kind of wake up and remind those smooth muscle nerves what they're supposed to be doing. That can occasionally help. But then you also have skeletal muscles, which allow you to kind of control your stream. And men have a much better external sphincters than women do, both from the urinary side and the rectal side, so that they have better voluntary control of that skeletal muscle. But that doesn't mean that, of course, they're not going to be influenced by some of the things that can happen from both the urinary side as well as the intestinal tract of what can go on with scleroderma. The downside to men having a nice long urethra is if they ever pass a bladder stone or a kidney stone. And you know, it's been said that passing a stone is similar to having a baby in terms of pain. And the only thing is at the end of passing a stone, you don't get to hold anything cute. You have a stone. so that's not really fun to take home from the hospital. With fecal continence, you know, it's a very similar system. Our alimentary canal begins from the mouth and goes all the way down to the anus. And with scleroderma, it's not unusual, of course, for you to have esophageal problems, but also for you to have intestinal problems, because peristaltic activity that allows your food to be transported to peristaltic activity in the small bowel, which is where our food and water and electrolytes are primarily absorbed, it goes in intermittent waves of peristalsis. So it allows the fluids and nutrients to stay in part of your body a little longer to enhance absorption. But what causes peristalsis? Smooth muscle. And so you can, sometimes it can go two ways. That smooth muscle isn't working properly, or it goes on overload for a little bit and things pass through too quickly, or it gets so far and it just decides to hang out there for a while. So it's there. You're getting bloated. Your intestine is becoming dilated. You feel nauseated. You get abdominal bloating. You don't feel like eating, and yet you've hardly eaten anything, and you feel like you're going to explode. In a normal GI tract, we eat. That stimulates our stomach. It's not surprising that when you smell your first cup of coffee in the morning, you might have to go to the bathroom to empty your rectum. It's not that it's all gone through you, it's that there's something called the gastrocolic reflex, so that when your stomach is stimulated, it in turn stimulates your pelvic floor and your rectum, and basically is saying, incoming, you know, so it wants to kind of help you get rid of whatever is there and make room for more. The best kind of stool to have, and this comes from working for years with colorectal surgeons and gastroenterologists, they wax poetic about the rectum. You would be very surprised. In fact, one of my colleagues was giving a lecture, and they were medical students, and they were kind of chuckling when he was just really talking big time about, you know, the rectum is just the best thing in the whole universe. It's like, yeah, right. And he looked at one guy in the audience and he said, I would like to see you whistle and chew mashed potatoes at the same time. And that's basically what your rectum can do when it's working well. You can have a full rectum, and there's a sampling reflex down there so that you know when you have solid stool, semi-solid stool, when you have gas, and when you can maybe selectively release that gas if it's in a private place or your brother's face is nearby. You know, that's I'm the only girl with all brothers, and they perfected that art, and I have 3 grandsons who are, you know, following in the family footsteps. And but that rectal reservoir needs to be distensible, and by being distensible, that means it will expand. You don't want it overextended, just like you don't want to overextend your bladder, but it's distensible. You get the signal to go defecate, you go to the bathroom. Well, guess what helps with that distensibility and that contractility? Smooth muscle. So you know, you're not crazy when you when you're saying, I'm having trouble both filling and emptying my bladder. I'm having trouble both filling and emptying my rectum. And I bet some of you who have that, if you've gone to somebody who isn't really experienced in taking care of very complex urinary or colorectal types of conditions, they'll say, and they mean well, they'll say, well, I don't see how that could be related to your scleroderma at all. But it is. It really is. Now, is there a magic lotion potion for it? No. Is there a magic surgery? No. There are some, you know, surgical interventions that you may be appropriate for. So if there's, you know, if you have an anatomical derangement, you know, your bladder is kind of flopping over or flopping out, or, you know, your rectum is moving around, those are some things that can be looked at. But obviously, with the whole disease process of scleroderma, nobody wants to go in operating on you unless they absolutely have to. So trying non-surgical ways of managing through behavior therapies, through, you know, lotions and potions and creams, timed toileting so that you try to get yourself on a schedule. And the big thing, of course, is still maintaining the competence of those sphincters. We really take our sphincters for granted until they don't work well, or unless you're overwhelmed. Because I'm sure many of you get that bloating and then you get explosive diarrhea. And it's like, okay, I need that path to the bathroom, or you're not comfortable even leaving the house because you don't know when or how it's going to hit. And so being able to predict is one of the best things, because we don't want our diseases or our conditions to tell us how to live our lives. We want to be in control. But being in control means knowing what might happen and how to prepare for those types of eventualities of what might happen. You have been through wonderful days of education, and more importantly, you are living this experience. So I am not going to lecture you on scleroderma, because I could sit down and you could teach me more than I know, because it is such a complex set of diseases and syndromes and symptoms. But what I can relate to you is some of the particular issues of how it relates to your GI tract as well as urinary tract. So how does scleroderma affect urinary continence? Well, all of the connective tissue, if you think of our pelvic floor as sort of being like a sling or a safety net in a trapeze that you see in a circus, that it's going to really help support all the structures in there, to both from an anatomical standpoint and a functional standpoint. But that connective tissue all is related to smooth muscle. And so in terms of functioning and how it works in terms of distensibility and contractility, all can be related to scleroderma. Now, some people are very fortunate and they don't have those pelvic floor problems that manifest themselves, but almost always you have something upper, so that whether it's esophageal with your stomach not emptying properly, or small bowel and bowel emptying problems, that is going to affect, you know, as far as your bowel filling and emptying, and really how you feel, and certainly nutrition-wise, and how things are managing and functioning. So any smooth muscle is a target for scleroderma. And of course, the research is absolutely tremendous. And we know so much more now about scleroderma than we did even 3 years ago. And just like all the complex autoimmune conditions and diseases, the more we know, you get more information where you are better directed in terms of research. And of course, research costs lots of money, and that's why trying to get the interest of researchers and investors and everything to help support, looking for not only how to manage the symptoms, but hopefully how to actually figure out and prevent and or cure the condition. When you have issues with renal hypertension, you're going to have problems not only with how your kidneys are able to function and filter, but you're going to have problems with how the urine is able to be transported along the ureters, and a risk of the urine backing up into the kidneys and causing kidney infections, or what's known as hydroureter, that where it's just not moving along well, your ureters become dilated because it's just very, very sluggish. Problems with bladder filling and emptying. The ureters enter the bladder at what's called the trigone area of the bladder, and they have basically what's a one-way valve mechanism, so that as the ureters enter the bladder, the urine comes in, but when the bladder fills, the urine doesn't shoot back up the kidneys, except, as those ureters are implanted into the bladder, guess what is surrounding that implantation? Smooth muscle. So if that becomes sclerosed or damaged, those ureters can remain open and end up causing a backflow and hydroureter. So, usually, they always make sure when they're checking all of you, and if you would do a CT scan, occasionally they might do an intravenous pyelogram or a retrograde study, because they want to look at bladder filling and any chance of reflux, because the symptoms when you start going into renal failure, you're pretty much asymptomatic until your kidneys are ready to shut down. So that's why being very proactive and making sure that somebody is checking your kidneys, going to a specialist, going to your urologist that really specializes in taking care of people with complex conditions, so that they can get a baseline and a jump on things in order to be able to better treat you and be able to prevent problems that you may have along the way. Then you may end up with some impaired function of your internal and external sphincters. The internal sphincters are managed by smooth muscle contractions and relaxation and contractions. The external sphincters are voluntary with skeletal muscle contractions. But when you have problems and you get basically parts of your body that just aren't distending and contracting as normal, that can affect your ability to either hold your urine or empty your urine. Just right next door is managing containing your stool. So that connective tissue supports and connects the entire alimentary canal. In the jejunum, which we have, when you go into the small intestine, you have the duodenum, which is just right off the stomach, and then the jejunum, and then the ileum. The jejunum is where the majority of absorption occurs. Your absorption of nutrients, as well as fluids and electrolytes. But big time fluid and electrolytes are absorbed in the ileum. Well, what happens if you have problems in the small bowel, in the jejunum, they look like little fingers. They're called villi, and they reach their maximum height in the jejunum to give more surface area to allow us to absorb essential nutrients back into our body. Guess what they're all lined with? Smooth muscle. Yes, so it all affects that kind of muscle line, and that's how our bodies are able to both absorb, because they can be porous and pull things in, but it's actually the muscles, the smooth muscle, that allow all of this to take place. So you can imagine if your smooth muscle is just not moving the way it should, and those, I like to think of it as when you see those undersea stories, when you see things just kind of flowing and nicely, and that's sort of what your villi are doing. It's like, oh wow, there's food, I'll absorb it. But what happens when scleroderma is they're just there. Or they become shortened and contract, and they're just not able to absorb all your fluids and nutrients. So that's why so many of you have to take elemental diets that are already pre-digested in order to help give you the nutrients that you need, because you're just not absorbing them well. And the difficulty swallowing, the esophageal changes that you experience early on, if they can give you medication that have a direct action on smooth muscle to try to stimulate that can be very helpful. But later on, once that smooth muscle becomes more fibrotic, it's obviously much more of a challenge. When things start going bad from top down, it's going to naturally affect all the transport and absorption of nutrients, and it's going to change the whole way your intestine is absorbing as well as making stool. So, we talked about one of the important things of being semi-solid stool. I bet for many of you, when somebody says, well, what's your normal bowel pattern? You kind of, do you want me to tell you 10 years ago? That's about the last time I had a normal bowel pattern. So looking at what is normal for you now, what was normal for you pre-disease state, and try to work out a balance of nutrition, of activity, of certain medications or stimulation that may in fact do a very good job of at least helping you manage those symptoms. One of the first steps, and it sounds really basic, is to keep a bladder diary. And when you go to a doctor, or nurse practitioner, or physician's assistant, and they walk in and they say, well, what's new? How you doing? And they're, and they're typing at the computer because most everybody uses electronic medical records. Frequently, they're just, they're getting whiplash because they're trying to look at you, but they're just, sort of looking away. You feel under pressure, and most of us are not at our most articulate when we're under pressure. A good healthcare provider will not be offended by lists. Because, and if they kind of back off a little bit, and you can keep it light and say, I just want to make the most of my visit here, and these are, and try to prioritize your questions, making sure that you get the most important thing there first, and some of the things that you have to know, and other things that are maybe nice to know that you can maybe get another provider to fill you in on. But having that is really important, I think, for you and for them, because you are the captain of the ship. You are the person that we're all here for. Several years ago, I was making a presentation at the American College of Colon and Rectal Surgeons, and they're a, dynamic group. They're quite a group. I mean, when people ask how you get interested in what you're doing, colorectal surgeons are the most fun people to ask about that. But they have T-shirts, "Butts are us," and all sorts of different things. But I was presenting on complex fistula management, and so at that time I was the only nurse, and during that session I was the only woman. And they had the surgeons, they had gastroenterologists, they had nutrition support, pain management, the whole gang. So they were all joking throughout their presentation about, well, I'm the smartest, I'm the captain of the ship, I'm the captain of the ship of the day, and I came up last, and my boss at the time, Dr. Victor Fazio, who just passed away last week, he was just awesome. Anyway, I got up there and I changed my, I did my presentation, and then I changed my closing, and I said, as a WOC nurse, I am very happy to serve as a crew member on whoever happens to be captain of the ship that day, but it behooves us all to remember the person that chartered the boat is the patient. There were about 5,000 surgeons from all over the world, and this was their main session. Dr. Fazio was sitting right where you are right now. He put his head in his hands like, oh crap, what has she done? And then one brave guy applauded, and then they started politely applauding, and then we had a panel discussion. And so I answered questions about, fistula management and pouching and odor control and skin care and all of that. And then one came up, they had questions from the audience, and they came to a microphone and said, yes, I'd like to address Ms. Erwin-Toth about her closing comment, and I thought, oh boy, here it comes. They're going to start throwing scalpels at me. He said, the silence was deafening, and he said, but you really jerked our chains in a good way. You know, we do forget. We get very focused on what we're doing and what body parts we are doing, and it's so easy for us to forget that person is the end result. It's why we are all here. So I want to thank you, Mrs. Toth. I thought, phew, dodged a bullet. They didn't ask me back, but that's at least not in the main session. That's beside that point. But knowing where you are, not where you want to be, is very important. And somebody's just staring at you and they're saying, well, what did you eat? What time did you eat? When did you move your bowels? When did you move your bladder? It's like, I don't, you're not going to think that fast. But there's complex bladder and bowel diaries, and there's very simple ones that you can keep. So you want to note your intake, about what time it was, and then when you had to go to the bathroom, whether you were emptying your bladder. Did you have difficulty? And this is common in men, that you just don't feel like you've emptied, because with an enlarged prostate, you can have overflow incontinence where the bladder is full and you only go just a little bit, or you're just kind of dripping, you're trickling when you're not really in the bathroom, and you just feel like you have to go. Same thing with women. You empty your bladder and you know it's not empty, and you keep going back. And does that second void help? Do you go and then 5 minutes later try to go again? So trying to find out your pattern is really important for anybody to understand how to help. The same with your diet intake. How are you timing your liquid intake with your food? Do you immediately go to the bathroom after you've had a meal? Is that stimulating your gastrocolic reflex? Or do you just feel stimulated all the time? As soon as you even put gum in your mouth, do you feel bloated, but you don't have to go? You don't have anything there to go. So maintaining that timeline and doing it for at least a week. I know it sounds kind of tedious. The longer you can do it, the better it is. And believe me, when you start bringing out your papers, they will want to kind of back out of the room. But if you explain to them, I just want to kind of show, and if you can sort of summarize and say, you know what, I seem to do better in the morning, but as my day goes on, things get really bad. Or conversely, I'm horrible when I try to get going in the morning. I feel bloated and uncomfortable, but after I get moving and I do this or that, it seems to help. When are you having accidents? Are you having problems? Are you having seepage? And when you get the periodic bloating, you can have those big blowouts. And part of the problem not only is the diarrhea that you can get. If you've been constipated, you can get what's called overflow diarrhea. You've got a big, believe it or not, there's a name for a big clump of stool in your rectum. It's called a fecalith. Isn't that exciting? Never see that on Jeopardy. But a fecalith, is this big, impacted ball of stool, but you have liquid stool coming around it. And so, some people say, well, I've had this loose stool, and they'll start taking Imodium or something like that, which is about the worst thing you can do, because you've basically got this ball of concrete in your backside. So, somebody with a knowing finger needs to go up there and figure out what's going on. And, you may actually need help to help break it up if you have that going. Other times you may have explosive diarrhea, and that can be partly because the ileum, which is where our bile salts are absorbed that allow us to metabolize fats and digest fats, and at the terminal ileum is where B12 is absorbed. If you're not absorbing that has a fun name too. Steatorrhea is really explosive, kind of floaty stool. Aren't you glad I'm not during lunch? Before lunch, but it'll kill people's appetite. But one thing that a colorectal surgeon or a gastroenterologist or a nurse like me will ask as far as your stool goes, is it a floater or a sinker? And you know what? That sounds funny, but it tells us a lot. If it's a floater and you see this kind of fatty stuff, looks like floating Crisco, that tells us a lot. That tells us that you're not absorbing your bile salts, that you're not absorbing fats, and that it's just kind of coming right through you. And so that can let us know a lot in terms of how to better manage your diet and your treatment. And if you're not absorbing your fats and digesting them, chances are you're going to be B12 deficient. And so that can certainly explain a lot of pernicious anemia, a lot of the tiredness. I don't know, for some of you who are I just turned 60 and my family had a big birthday party for me, but I remember when I was a kid and they had those Geritol commercials. Anybody remember those? For iron poor, tired blood. What they didn't tell you is that they were about 40 proof alcohol. Now my grandma was from Mayfield, Kentucky. And they were very, very, very teetotaling Baptists, all right? If you ever even smelled liquor, you were going straight to hellfire and damnation. Well, Grandma would take her tonic, in the evening. I'll tell you, after 8 o'clock, Grandma was drunk, and she was in bed, knocked out. So, we knew, but oh no, and my father tried to tell you, Mother, that is mostly alcohol. No, this is medicine, this is my tonic. And but it was just so funny. It's not quite that way now, but I bet there are places where you can get the good old Geritol. But there's a lot of things that are advertised on TV, and you always have to be so careful about taking anything that is going to either increase motility, decrease motility. With your condition, it can have a really big ripple effect of what's going to happen in terms of how it can affect you. So that's why, you want to partner with that gastroenterologist. You want to partner with a urologist that understands what's going on with scleroderma, because as men and women, we're all going to have some individual problems that are frequently normal as part of aging, but you've got the double whammy in there with scleroderma. So your management approach is going to be different, as are your presenting symptoms. But if you can relate to them what's going on and what you're experiencing, that is a great way for them to be able, your healthcare provider, to help work with you on a plan that will help. Well, so, what symptoms can you control? Looking at timing, looking at skincare. What resources are there available out there for you? And good information. Everything is available on the internet, but probably only 10% of it is true. So you have to be really careful to look at the information that's out there and make sure that it's good. Now, the National Digestive Clearinghouse is through the National Institutes of Health, and those are our tax dollars at work. So if you do some Google searches and look on some of those government documents, there's great resources on bowel and bladder management, other disease state management, and they're very much good as far as giving you a guide. I don't know why some of my little pictures didn't show up. Well, when it comes to managing incontinence, you want to be sure, and this is not a commercial address by any means, because there are primarily 3 steps that are essential when it comes to skincare incontinence. And this is evidence-based practice. It's used by my specialty nurses, WOC nurses, as well as people who specialize in managing skincare, that if you can prevent problems and maintain a good skin environment, you can help prevent breakdown and you can be prepared. So using a cleanser that is pH balanced, that's for adults. A lot of times people automatically reach for baby products, and the baby products just are, well, they're designed for babies. They're not designed for adult pH and adult needs. Our skin is very different as we age, and your skin is particularly different because of scleroderma. Look for a very hypoallergenic type of skin cleanser. You don't want to cause trauma. You don't want to have to rub down there, because if you break that barrier of your skin, you don't have all of those resources at the ready to help you build it back up. So using a foaming no-rinse skin cleanser really will help lift up urine and stool without needing a lot of friction. One of the worst things you can do is one of the old remedies that a lot of older seasoned nurses and nursing assistants used to do is get that washcloth and that heavy-duty dial soap and scrub the daylights out of you. All they are doing is ripping off your surface skin. They're ripping off the epidermis and leaving you exposed to bacterial proliferation as well as skin breakdown and difficulty healing. So that using a really good skin cleanser without using, a lot of friction, then to protect. Now, if you don't have problems, that's terrific, but if you have periodic problems, using a petrolatum based, it's not petroleum, it's a further refined version of petroleum jelly. It's petrolatum, we're not just making stuff up, but it's what it is provides a really good barrier around the anal canal. And as I talked to you, many of you stopped by the Wellmedics booth. I do work part-time with them, but any of the fragile skin protection you can use all over your body. So if you apply it while your skin is slightly moist, it's going to help retain that moisture but not have moisture overload. So they have multi-uses. So the no-rinse cleansing foams can be used not just around your bottom, you can use it as a shampoo because occasionally you get really dry, hot spots, uncomfortable spots. It's going to offer a lot of a soothing environment that isn't going to dry your scalp or isn't going to dry your bottom. So it's kind of a multi-use thing. The same thing with protecting fragile skin and then treating any types of rash. Don't just go to the baby aisle and get Decident. Go get a product that is designed specifically for adults to help with, it's called adult-associated, incontinence-associated dermatitis. And it is a fancy word for diaper rash in grown-ups. But the way we manage it certainly is to prevent it and then treat that skin so that it is going to, will create an environment for healing. If some of your problems are predictable, you know that, oh my gosh, I'm feeling so bloated when I feel like this, I know I'm probably going to have a blowout, apply these preemptively. Make sure that if you do use a pad or a pant, that you're using one that is designed for adults. Women have a tendency to just reach for sanitary napkins. That's not good because that's not going to wick away whatever is coming out from your skin. Look for something that has a permeable membrane that is going to pull the liquid away from your skin and into a separate pad. If you do have problems and you need to wear a pad or a pant, leave it open when you go to bed. Don't capture things. Don't trap all that moisture at night. So, sleep on a nice absorbent pad on your bed because by pulling up a diaper tightly at night, it can really lead to terrible skin breakdown as well as fungal infections. And of course, fungus love to grow where it's warm, moist, and dark. And so, we want to, kind of manage these symptoms and keep you going, but always asking questions. So as I said earlier, you are not scleroderma. It does not define you as a person. For many of you, all of you that are here, you have such tremendous courage, and the knowledge that you gain is knowledge that I know you share. Many of you are here on scholarship from your local chapters, and that's just wonderful. And we also need to have a voice. I'll do my little political pundit here. We need to have a voice with those that represent us. Our politicians, they work for us. I think a lot of them forget that. And the scleroderma isn't a popular condition. They don't want to get up and talk about, you can get up and show a baby, oh, this is a cute baby, they have this. But when you talk about the needs that as a community people with scleroderma have, it's not glamorous until somebody famous gets it, right? Michael J. Fox, I would never wish ill on anybody, but he has done so much for Parkinson's research because, a young man, dynamic actor, came down with this and his voice has been heard. So, yeah, keeping that voice active and keeping open and communicating with our elected officials that, this is important. And just because we're a small group doesn't mean that we're not worthy of attention. You can be small but mighty. And remember that incontinence itself are symptoms that reveal an underlying condition. There is something else going on. Just like the symptoms when you were trying to figure out and get diagnosed with scleroderma, there's something going on under there, and hopefully they can manage those underlying symptoms. But in the meantime, we need to take care of that largest organ of our body, our skin. Always ask questions. If somebody won't answer them, go find somebody else. And my mom passed away a few years ago, and of course caring for me with a condition that nobody really knew much about, and there was no internet. There was nothing but libraries available, public libraries. And she went to one doctor, and we were referred there, and so she had a list. And he looked at her very kind of scathingly. Well, I see you've been reading again. Yes, and I'd like an answer. And then we didn't go back. And my mom was about that tall and, that tiny, and she was very quiet and self-effacing, like I'm sure many of you are. But boy, when it came to being an advocate for me, she was like a lioness with her cub. And that's what you guys need to be. You need to be that lioness with her cubs, even if you're a lion. Be that lioness and advocate for yourself, because if you don't advocate for yourself, you can't count that on anybody else doing it for you. And knowledge is power. The more we know and the more we share, the more progress we're going to make.